This is a typical setup that I have. Essentially, the patient has been nasally intubated, and that allows us a better access to her floor of the mouth. I do use a little bite retractor to keep the mouth open. And then we're going to pan to our Mayo stand. This is fairly basic setup when we're doing sialendoscopies. Essentially, these are the Stort's duct dilators and a conical dilator. These are some of the forceps that we use, and here's the Cook dilators, and these are the sheaths that we use, which allows us to maintain the access. So you can see my bite retractor here. I'm using my fingers to basically show me the floor of the mouth. You can see the frenulum, and we're looking for the duct opening. So this is the one on the right, and usually there's a mirror duct on the left, which we can see right here. So, in doing submandibular sialendoscopies, the most difficult challenge is actually finding the actual duct itself, duct opening itself. And today we're going to be using the Cook dilator set. So we start off with a guide wire. Goes in.
You put that in under direct visualization?
Yes.
Or yes. With your microscope, but I'm saying you don't have to put any other kind of guide to get it in.
No. This tends to essentially slide right in, and you want to go the length of the duct. So my nurse will pass me my first dilator. It's a 4 French dilator. These are coated. We're going to slide it in, and you're going to see that coming into view very soon. To start, and as you can see, it's gone right in, and so essentially we're in. She's young and she's quite petite, so her papilla is quite small and her duct is quite small. So what you want to do is you basically want to allow some time for the dilatation to occur before you go to the next size up. And the next size up will be a number 5 dilator, and all I'm doing is just moving the dilator in and out, just stretching the papilla open. In occasional cases, you can, if it's really tight, you can also do a little papillotomy, but I'd like to avoid that if I can. So what I'm going to do now is I'm going to retain my guide wire in, slip out my dilator, and we're going to change over to a number 5 dilator. It's the Salinger technique. The idea is the same as if you were to do a percutaneous tracheostomy. You're basically dilating the tract as you go along. So that's the number 5 dilator going in.
So, and if I understand correctly, you leave the wire in place while we're doing the serial dilation so that you're not damaging the posterior wall each time that you're going in with the dilator, which I think could potentially be an issue, so that here you're able to use this as a rail.
So I'll just put the number 6 dilator in, and now we're ready to put the sheath in. So the access sheath that we're going to use is a number 5 access sheath, and Dr. Valvacar made the point before that you don't have to use this in all the cases, but certainly when you're using it in cases where you are going to make a number of passes, this makes a huge difference because it allows you to become much more efficient and you're not traumatizing the papilla. The idea that for this came from the fact that I would be doing cases, and essentially, when I'm taking the scope along with the fragments, stone fragments, the papilla would basically be traumatized, and I would have to abandon the case. So what you see right now is essentially the guide wire. Here's a dilator that's preloaded with a sheath, and then the sheath, there's a smooth transition, and we're getting in. And you can actually slide this quite far in. It'll go all the way to where your obstruction is. It basically goes all the way to the area of the hilum. So that's our access port. Then I disengage the dilator, I keep my guide wire in, and I'm going to load my scope over the guide wire, which I'm going to do right now. In terms of whether, what setting you're doing this, whether you're doing it under general anesthesia or the OR setting or in the office, as Dr. Valvica pointed out, it all really depends on what you have available. And certainly, this case could have been done under local. Having said that, when I did this under local, the diagnostic, she wasn't very comfortable. So, you have to take into consideration what your patient is like in terms of how they're going to behave under local. So now you're seeing, essentially, I'm going in, and I'm following the guide wire inside, and look, and there's the stone. Irrigation, please.
So are you flushing fluids while you're doing that?
Yeah, so we're doing that right now. My assistant will essentially start flushing, so they'll open up the duct, and then you can see the duct is going to start opening up. Keep on going. You can see the guide wire, and you can see the floating stone. So here's our stone. I'm going to take my guide wire out, and we're going to basically introduce a basket. So as you can see, the basket is in. I've deployed it, and now what I'm going to try to do is to basically rotate it around the stone. Close
Now
the
that's
basket.
a side capture basket?
No, it's an end circle basket. So you can see the stone being basically engaged. And now what we're going to do is we're going to slowly take, the stone is too big to obviously come through the sheath, okay? So we're going to basically withdraw everything all at once. And as we're withdrawing, we should see the stone following the sheath. You want to basically gently withdraw. So what I'm going to do is I'm going to take my little scissors.
But you have to be really careful in that situation. You don't want to pull harder. You will and can avulse the duct.
Okay.
If the stone gets caught, like he demonstrated earlier.
Okay. Okay, very good point.
The Ballucci scissors here is really a nice addition. It's the right instrument to make that papillotomy. I find that the knife sometimes doesn't give you the same amount of control.
Okay.
Now, were you guys able to see that?
Yes, absolutely.
So the scope, basket, stone is out. She's going to be a really happy young woman.